This presentation I'll be discussing with vascular emergencies. So, before I embark on the next slide, I'll give you 1 minute, or you can pause the video for a minute and list the vascular emergencies that um, come across to your mind. Pause the video and then write and compare with what I have given. So, when you think in a broad manner, vascular emergencies could be arterial or it could be venous, and also there's a special category where your arteries and veins is not the primary problem, but there's what is called compartment syndrome, which we will discuss later. But looking at the problems a artery can happen face as an emergency, of course, it's two. It's a structure which takes blood down, so it can get occluded or it can get breached and start bleeding. So the arterial occlusion, the pathologies which can cause occlusion are of course thrombosis, embolism. With a dissection, it can get occluded, especially when an artery dissects. The ostia of the supplying vessels from a main artery, it is a major vessel. The usual is the aorta which dissects due to the high pressure, and the branches, the ostia, can get suddenly occluded due to the dissection. And also artery can get occluded by injury because the continuation is breached. It may be due to division of the vessel, or maybe injury, it is get thrombosed or spasm. Then bleeding from artery, commonly it's due to a rupture due to an aneurysm, or it may bleed by an injury. Similarly, venous, it can either get occluded or could bleed. Occlusion, superficial vessels, the thrombophlebitis, which doesn't cause a major problem except the discomfort the patient is having, and the deep vein thrombosis. Then bleeding, again, could be rupture, commonly following varicose veins with the wall weakening, and also it can bleed from injury. So it's a very broad concept, and for each region of the body, it is possible to apply all this and see in some regions, some may not happen. But say you take the cerebral circulation. So with occlusions, the person can present as a cerebrovascular accident. Especially it is the embolism, then thrombosis of course can happen, but embolism from carotid artery plaques, embolizing and causing a ischemic stroke. And also head and neck vessels can get damaged. So it could occlude or mostly it will bleed. Then rupture of aneurysms. Again, the cerebral circulation, like the circle of Willis, you can have berry aneurysms which can rupture, bleed and cause a hemorrhagic stroke. Venous neck veins, of course, can get thrombosed due to various reasons, and with injury they can bleed. Compartment syndrome in the head. Actually, we don't talk as compartment syndrome, but it is actually a very special form of compartment syndrome when some bleeding happens in the intracranial compartment or due to some other cause like inflammation, like either mostly encephalitis or cerebral abscess or a cerebral tumor, as the cranium is the most tight compartment that we know. A slight increase of pressure will lead to not only a compartment syndrome in the usual sense, and also it may even compromise the arterial circulation coming into the brain, because there's a very high rise of the intracranial pressure. But it is actually not usually labeled as compartment syndrome, but of course the concept is there. So any region, you can take the thoracic region, how these various things may apply, but I'll not go into that form of discussion now. And most of the time, but anywhere these things like even abdomen, you can the aorta can get thrombosed, usually following in a aneurysm, and they can embolize distally. The aortic, the abdominal aorta can dissect, aneurysm of the abdominal aorta can rupture, or it can get damaged by injury. The IVC can get occluded by a progressive deep vein thrombosis coming from the leg, or due to other reasons like the portal vein can get occluded in problems of the liver, portal vein thrombosis, and also they can get injured and bleed. So anyway you can apply, but the future discussion will be where this in a surgical unit where vascular emergencies, a common thing is happening in the lower limb. So when there's a vascular emergency of the lower limb, most of the time they present as acute limb pain due to the occlusion of the vessel, maybe due to thrombosis, embolism, or maybe due to injury. So I will discuss most of that part, leaving out the other things, and compartment syndrome I'll discuss at the end because it is also cause for vascular emergency in the leg. So with ischemia, actually the presentation is the person comes with a acute pain of the limb. So my next discussion to keep in a clinical manner, I'll take it as acute limb pain. So take a while and read this scenario. And now pause the video and list the possible causes for this. So these are some few causes for acute limb pain, and with a very short duration, the first thing that we have to think and exclude is acute limb ischemia. And trauma is a cause of acute pain, but of course it will be obvious in the history, or it may be an infection. Sometimes with infection they can have severe pain, especially deep infections like osteomyelitis, or a deep infection within the deep fascia like some form of myositis. But of course the history may be a little longer than 6 hours usually, and an acute lumbar disc prolapse can cause it acute limb pain. But few questions will rule out these, like these obvious, an absence of fever and usually long history with pain building up with gradually, and then neurological symptoms of having backache, and also other things of neurological symptoms like some sensory loss or motor weakness peculiar to the disc which is prolapsing, and also the history of a neurogenic claudication. Examination will come later, but of course there will be a positive SLR and absence of signs of acute limb ischemia or infection. So once those are excluded, with very quickly you can exclude and palpate the pulses, it will confirm the acute limb ischemia. So the person presented actually didn't have any trauma, there was no fever, no neurological history suggests all lumbar is prolapse, and feeling his leg, it was very cold, and the distal pulses were absent. So now what are the possibilities in this patient for acute limb ischemia? Because we have to think in a pathological manner. What are the possibilities for an occlusion? So you can list the possibilities for acute limb ischemia. So this is what I was discussing earlier, how there's a quick exclusion of the causes and confirming its acute limb ischemia. So now this picture shows the typical features when the ischemia sets in, and it's delayed actually. To get all these things, it's actually a delayed. And pain will be there from beginning. It will get cold, but of course pulse will get absent. But for paralysis to develop, paresthesia to develop, it has to take some time. But anyway, these are the causes for acute limb ischemia. It could be embolism, could be a thrombosis, vascular injury, or compartment syndrome. So we have to find the cause because the treatment will be different. Vascular injury is excluded in this patient because there's no history of trauma. So that's out. Compartment syndrome, I'll take in a while, but with this pulse being absent, it has to be one of these two, because absence of pulse is not a diagnostic compartment syndrome. But of course, there can be secondary compartment. Don't get confused at this moment. But this person with this problem of coming with the severe pain, other things excluded, and pulse being absent, no trauma, it has to be either embolism or thrombosis. Now, how to distinguish from one another, thrombosis from embolism, or vice versa. Now, again, pause the video. It is good to have this interactive and just check your background knowledge, because if it's okay with what I am presenting, or maybe your knowledge is better, you can be happy. If not, of course, you know that you have to do some more reading, because by this stage, you should be in a position to distinguish one from another. So write up what comes into your mind and look at the next part of the presentation after that. Now, so the rest of the history and examination, the main thing is that we have to find the cause, and after finding the cause, of course, we have to get to a specific inquiry just to see whether this problem has affected other systems, or the pathology causing may have other problems in the other systems, and also to assess the person as in general. Say like if it's a embolism, the systemic inquiry will tell us from where, possible site where the embolism came. And if it's a thrombosis due to a chronic PVD getting acutely occluded, your systemic inquiry may show the previous, whether he had chronic leg ischemia, and also whether other systems are suffering from arterial occlusion, especially if it's a cause of atherosclerosis, like CV or past CV, or whether he has some cardiac ischemia. So this is very important. Then other sections of the history to manage the patient, it will be important, because the person, say like a diagnosed valvular heart disease coming with a embolism, maybe now the person may be on warfarin, so it's a problem for a surgical management, or the person has ischemic heart disease and he's on aspirin maybe, and other comorbids which are important to manage the patient, like diabetes, surgeries, allergies, so if you are going to do a angio urgently. So all parts are equally important. But then differentiating the thrombosis and embolism from the history, so check with what you have written whether you have got all this. So with embolism, one thing is that there is no previous history of intermittent claudication or other features of peripheral vascular disease. because thrombosis happens in a previously partially occluded vessel. But embolism, the leg vessels are okay, the fault is somewhere else, and from a thrombus there, part gets embolized, and all of a sudden the leg ischemia starts, though there's no previous history of chronic leg ischemia in a case of embolism. So, if the previous history of a chronic leg ischemia is there, it is more likely to be a thrombosis than not an embolism. So, this history is important. And in embolism, there will be history suggestive of the embolic source, or maybe it is diagnosed already. A person who has a valvular heart disease may be diagnosed on treatment for that. But all the history may suggest you that he has some features of arrhythmias or cardiac failure, something like that. And examination will confirm the embolic source, like a cardiac murmur or a abdominal aortic aneurysm. And generally, because the commonest site of occlusion is being the external iliac, this common has to actually go off. It can be the common iliac artery, but most of the time it is the external iliac artery or the common femoral artery. So, because the sites where the artery gets narrowed, of course, there's no reason why it can, small clots can even embolize distally and cause a thrash foot. But most of the time, with a history like this, the occluding areas are that. So, usually, maybe fortunately, it happens only in one limb. But you can have a saddle embolus suddenly occluding both limbs. So, with a no previous history of chronic ischemia, suddenly one limb get occluded, and you feel your femoral pulse is absent, and you examine the other limb is normal, all pulses from femoral downwards felt, it's more like to be embolism. So, if I repeat, the person has no history of previous chronic ischemia on the leg, has a source history or diagnosed source of embolic source, and one limb getting affected with the femoral, from femoral down being absent, very likely to be embolism. And also your examination will show no evidence of PVD like hair loss or features of chronic ischemia, nail changes. But with the thrombosis, you will have this previous history of PVD, and even the one in one leg it is more, the other leg also may have features. And when you look, there will be chronic limb ischemia features usually affecting both limbs, like loss of hair and the pulses. Now, this person has the sudden pain in one leg, but even the other leg, say, so we'll just think that this person had a chronic ischemia occluding the superficial femoral artery, and he gets this thrombosed, and that leg has acute pain. But when you examine the other limb pulses also, because of the chronic occlusion, maybe he has absent pulses, even though he is not having acute pain, because his collaterals are maintained because there's no thrombosis. And also, we have excluded a embolic source. So, quick history. The key are the previous history of the chronic occlusive disease, the history plus the examination findings, and here it is not there, and there will be an embolic source. So, it is easy to diagnose it. And for confirmation, of course, arterial duplex is there. If you need more evidence, a CT angiogram, and here you can see there's a acute thrombus there. Now, supposing you have a person with a valvular heart disease. Leg was okay before. Sudden pain, femoral downwards absent. You know it's embolism. Now, if there's just arterial duplex is more than enough. You don't have to do a CT angio, but even the arterial duplex, if it's taking time, if it's going to delay your treatment, you may just embark on the embolectomy without wasting time. But of course, for thrombosis, because the management has little more, you may prefer at least to have arterial duplex. But in a acute situation, everything is clear, this is getting delayed to salvage the limb. Of course, you may do some emergency procedure, which we will discuss later. So treatment, it is straightforward. Once diagnosed an embolism, it is embolectomy. And you have to really understand that the femoral embolectomy can be done under local anesthesia. So there is no reason why you should delay the treatment, either because patient is not fasting or the person has some cardiac failure due to the primary problem. There's no reason why you should postpone. You can do this under local anesthesia. And if it's a thrombosis, of course you can do a thrombectomy or you can do a thrombolysis. When you compare, this is surgical thrombectomy. Of course, now even radiological, they do thrombectomy sometimes, radiology guided, but mostly it's surgical. But thrombolysis is a radiological guided because you thrombolize with a catheter in that artery, giving direct thrombolysis because it's not considered a systemic thrombolysis here. But this is a slower process to get the results, and also what you lyse may distally embolize. But only thing with these two, the thrombectomy, thrombolysis, now this vessel is diseased already and it's now got a clot suddenly, and you thrombolize or thrombectomy, there's a chance that it may clot again. So it's very important to put them on anticoagulation, even them to start anticoagulants. So here that risk is there. But of course, if you salvage the limb, you can do a definitive procedure, angioplasty and stent or a bypass depending on the various factors. So after salvaging the acute phase, you may do this more planned. Or of course, if everything you have a good vascular need, patient is good, you may even do this urgently. So the permanent treatment urgently. So this is how you diagnose in acute limb ischemia. After excluding these causes, the embolism and thrombosis, how we diagnose by the history, examination, and then how we treat it. And the other two, the vascular injury and compartment syndrome, I'll discuss in the next section of this lecture.